It's really good to see everyone. We have a really interesting and important lineup of contributors to this evening's discussion. Not the least of whom are you all who came out to to speak with the folks who are listed on the agenda. Each of them have an important angle and perspective and expertise. But one of the hopes of this evening's meeting is to begin to put shape onto an ongoing series of conversations so that this is not the only discussion about healthcare in the PSC, but becomes a baseline for beginning to have a series of strategic conversations about healthcare and the PSC. So as I imagine many of you probably know, I'm James Davis. I'm a faculty member at Brooklyn College and also the president of PSC, and I'm excited and really grateful to the folks who pulled this together, especially leaders in the Social Safety Net Committee. Critical discussion. Many of you already know that the Social Safety Net, I don't know to call you guys a task force or a committee, but I think it was all the way back in 2011, where the union made a commitment to establishing a task force on this range of issues that fall under the umbrella of social safety net. And the work that they've done over the years has been really critical in terms of educating the membership and organizing. And so, this, as I said before, hopefully is an important springboard for additional brainstorming and discussion. And as you'll see as we go along, there's going to be a questionnaire. We're going to ask folks to complete an online web form to help inform additional iterations of this conversation. So the PSC as a labor union, we have supported as a goal, just in broad strokes, we've supported as a goal a single payer universal health insurance, and that's just an important framing to start with. How we get there, how we achieve that, for in New York State, for the country, is a whole other bigger political and strategic question. But I just want to put that out as a kind of baseline premise for the discussion. And I thought it would be helpful if I could just, before turning it over to Bill, map out a couple of the contexts in which the PSC moves. And you'll have to forgive me, I don't want to go into the weeds on these, but I think it's just important that folks who are new to these discussions understand them. And as I look around this room, I see a lot of people who are not at all new to the discussion, but just so that we're roughly on the same page here, I think it's important for people to begin with an understanding of some things that it took me I am embarrassed to admit, indeed many years to fully wrap my head around how we as a labor union are positioned in relation to healthcare. One of these is that the PSC does not negotiate directly for its own health insurance. And that's just an important fundamental thing, and others are going to speak to this, that the Municipal Labor Committee, of which we are one member union, negotiates health insurance for us. It doesn't mean that we don't have a voice and influence or a say in health insurance. But I think as this Medicare Advantage, fiasco underscores, we are in a relationship with other labor unions with respect to health insurance. And, there's a way in which this, the Medicare Advantage negotiations have shown that the retiree health insurance can be, a kind of a canary in a coal mine and a wake-up call. Rising healthcare costs are going to be part of what several people are going to speak about today, nationally and in the city, because they exert so much pressure. Rising hospitalization costs, rising prescription drug costs, rising costs of delivering medical procedures exert pressure on a system where we have been able to enjoy to date premium-free health insurance, right? And so the pressure that exerts on the city to continue to provide premium-free health insurance is formidable, and we need to be able to grapple with that. And there's pressure, and we're thinking ahead here about about the pressure that exerts on labor unions looking ahead to negotiating contracts, the pressure that exerts on the city, right, in terms of passing that cost along to active employees, is potentially going to be very intense. So I think that's part of what we're preparing for. And as you all know, and this is the last thing I'll say, pass it over to Bill. As you all know, and again, another thing it took me some time to really understand fully, CUNY engages in what they understand to be pattern bargaining. So in addition to being a member union of the MLC, we are also in a relationship, not an intractable one, but one that does exert pressure on us as a labor union, of entering into what CUNY understands to be the pattern in the city, around wages and benefits and other matters. So I think there's ways that I would say we have the opportunity to move and to organize within those conditions, form coalitions, and some already exist that we can bolster and exert our influence in those coalitions. There's also legislation that people will speak about tonight, ways that we can exert our influence on getting legislation improved and passed. And then last but not least, of course, our greatest resource is our members. And so I think part of the purpose of initiating tonight's conversation is to begin to bring additional layers of engaged members, some of whom are in fact experts on health policy and related matters. So let me kick it over to Bill, and thanks for the opportunity to begin laying some of those issues out. Bill?
Yeah, thanks, James. I mean, this is a session on what's happening to our healthcare. What does that look like historically? What does it look like prospectively? Where do we fit in? What kind of agency do we have? What's the context for all this? Who are the players? I am not an expert on healthcare policy, but unfortunately, and I underscore the unfortunately, I've learned a lot over the last year and a half, because using James's metaphor, used metaphor, I was one of the canaries in the coal mine. The retirees were canaries in the coal mine. Our healthcare has undergone or is undergoing drastic changes. And as a result, we've learned a lot. This is not mainly a session about retiree healthcare. I'm not going to talk ad nauseum about retiree healthcare. We want to focus on what's going to happen to in-service healthcare. And to help us do that, we have a number of speakers. And what I want to do is turn it over to Barbara Caress, who teaches healthcare policy at Sarah Lawrence and at Baruch, and is the consultant extraordinaire for the PSC. And she's going to talk briefly about healthcare reform in New York State, and then she'll turn it over to Debbie Bell, and Debbie will turn it over to others. Barbara?
Okay, thanks, Bill. And I'm going to put some slides up, and I hope you all can see them. More easily said than done, but what I wanted to do was just set our discussion of healthcare and healthcare policy, not particularly about the PSC contract. What is going on here? Here we go. In a context of New York State healthcare reform, and it is a very interesting history. And I thought I'm going to take 5 minutes and run through it. Making 3 points. One, health reform has been on the state agenda for more than 70 years. It's influenced by both what happens in the state and what happens in the country. And I want to do a last slide showing you a very interesting slide about the relationship between healthcare cost and quality, because I think ultimately it's all of our goal to have affordable, appropriate, quality healthcare. So I'll end with that slide. So I have 3 slides, and here's
Barbara,
my first.
Sorry, Barbara, first, just so you know, we're seeing the Zoom entry screen from you. So I don't know if you have to unshare.
You're not seeing, you're not, oh my goodness. Hold on 1 second. Let's see if, can you see this?
Yes.
Yes,
Yes.
it's beautiful.
Okay, good. Thank you. Thanks for stopping me. That was quite. So here's my first slide. And what's most interesting, this is a wonderful little clipping from the New York Times from April 15th, 1970. And you'll read the headline. It says, Medicare for All is asked by Javits. Javits was a Republican senator from New York, and this is a proposal put together by Javits, Rockefeller, assisted by Wilbur Cohen, who was the first secretary of HEW, who was the administrator of the Department of Health, Education, and Welfare when Medicare and Medicaid were implemented. And so just to say, first of all, this is obviously not a phrase coined by Senator Sanders. But secondly, when the bills were passed in 1965, the Amendment to Social Security Act, Nelson Rockefeller, who was governor, used it as an opportunity to extend the coverage for Medicaid, because initially he could do this, to 40% of the population of New York State. And just to give you a sense of what that meant, it meant a family with income below $6,000, and to say the poverty line at that point was about $1,200. In the first year, New York spent 28% of all the money that was spent on Medicaid. The Congress changed the laws. They forced Rockefeller to tamp it down significantly, and basically the rules said only the very poor were eligible. So that's one piece of the context. My next slide is, I just want to show you some of the milestones in this period. And as I said, some of it is local, most of it is national. So the top, my red arrows are Medicare and Medicaid, 1966, 67 implementation. 1975, the New York City fiscal crisis, which caused a significant cut in, New York was regulating both Medicaid and Blue Cross. And there was a 10% across the board cut, which created an enormous crisis in the health sector. So it resulted in what was called the Council on Healthcare Financing, who established a system whereby New York regulated all hospital and some doctor rates for Medicaid, Medicare, commercial insurance, and Blue Cross. So we had basically a totally regulated system that existed until 1996, when Pataki was elected, in part on the promise to deregulate the health system, which he did. He not only deregulated it, but began a process of privatization whereby the Medicaid system, which was pretty much state-run, was turned into a Medicaid managed care system and subcontracted to private insurance companies. There were also, though, some elements of this that were pretty interesting and remain in place. One was the creation of a charity care system where everybody is taxed in one way or another to create a very substantial pool of about $6 billion that's spent to subsidize healthcare for uninsured people. And secondly, New York, and as part of its ACA implementation, created the Essential Plan, which is essentially premium-free insurance for the working poor. So that we have Medicaid for the unemployed poor and the Essential Plan for the working poor. So in New York State's achieved an insurance rate of about 95%. And most of the people who are uninsured are undocumented. The majority of people who are uninsured in New York State are undocumented. So that's the context. And I have one more minute for my last slide. This slide shows you, it's a very confusing slide, and deliberately so. The green lines, the vertical lines, each represent the hospital, and it shows quality scores. Hospitals are scored on how well people survive from common illnesses, how many people get infections after surgery, a whole series of pretty standard scores. And you can see that there's quite a bit of variation from the highest to the lowest on the green line. And the blue line that jumps up and down across this screen is Medicare reimbursement, which is to say there is absolutely no relationship between cost and quality, between price and quality. That's a very important fact to keep in mind as we think about how we at PSC are going to try and influence state policy, local and state policy. So with that said, I'm going to introduce Debbie, who is now in 5 minutes going to take you through 75 years of history of the Municipal Labor Committee.
Yes, and so I'm going to talk very fast, and we will go over this again because there's a lot of facts in here. Health insurance for city government employees, including CUNY, goes back to 1945. So it predates collective bargaining in the city. Mayor LaGuardia, all hepped up about the idea of national health care, which was an active discussion in Congress, encouraged the establishment of HIP as a nonprofit health insurance plan in New York City, and invited municipal employees to be part of it, along with Blue Cross, which Barbara alluded to, another, at the time, nonprofit entity, which for hospitalization. The idea was municipal employees then paid half the cost of the insurance. Many, many people signed up. Going on through time, collective bargaining did not come to New York City until 1958, when Mayor Wagner signed an executive order formalizing that the collective bargaining process. And there was a lot of unionization. There was a lot of stuff going on around it, but the formal start was in 58, 13 years later. In 1965, the city decided to offer different types of insurance. That's when GHI as a fee-for-service plan started. And also in 66, the city assumed the full cost of health insurance for active employees and for retirees, and incorporated the eligibility for health insurance in the administrative code. Sidebar here, retirees who are in TIA-CREF annuitize some part of their retirement so that they can be eligible under the administrative code. That is their pension. So the Municipal Labor Committee, which James alluded to in his introduction, that is the collective body of unions representing municipal employees, which negotiates about health. That was established in the 1960s, the late 60s. There's a lot of politics behind it, which I won't go into at the moment, but it's very interesting and sort of explains some of the dynamics we see today. That group, largely led in the beginning by DC 37 of AFSCME and Local 237 of the Teamsters, a few years later joined by the UFT, began to bargain about health issues and also did legislative lobbying around pension and agency shop. Then came the fiscal crisis in the 70s. And the MLC took on ever more significance because that was the body that bargained with not only the city, but also the financial interests in trying to resolve the pension system. A key note here is that the MLC, as a collective body of union leaders, offers local leaders a kind of buffer between their rank and this you saw in the fiscal crisis, and I'll cite our own Michael Spear making this point in his dissertation. You saw that rank and file members were often very angry at their leaders negotiating away, perceived as negotiating away certain things. MLC was a buffer. Oh, well, the MLC is doomed. I'm moving along fast. It's important to note that since the fiscal crisis, there has been coalition bargaining, as James noted, around economic issues. At one point, everybody bargained together. At another point, there were civilian unions together, uniformed unions together. Now we have evolved into pattern bargaining. But I should also note that also during the 70s, what began to appear were welfare funds to provide supplemental health benefits. Those funds are actually controlled by individual unions and offer different benefits depending on which fund you're talking about. The 1980s was a period of greater fiscal stability, but that's also a point when prices were going up and healthcare costs were rising, particularly for GHI. That is when the city pays for health insurance based on the HIP rate, which is worked out between HIP and the state of New York, the insurance department. GHI costs began to go above the HIP rate. GHI turned around and said, well, we're going to have to reduce benefits if you're only going to pay the HIP rate. At that point, the MLC negotiated a balanced funding mechanism, shorthand for which is now the Stabilization Fund, to stabilize the relationship between benefits and expenses. That was also when the city started expanding the range of health insurance options beyond simply GHI and HIP. In the 1990s, the role of the MLC bargaining health became ever more explicit. And in overall collective bargaining, that's when the emergence of pattern bargaining began. An interesting historical note is that Mayor Giuliani in the mid-90s froze how much the city was willing to pay for health insurance. Whatever the HIP rate was, he wasn't going to pay any more than he was paying in 1994. That had the effect, after that ran out, of HIP seeking enormously large increases in their rates in order to restore their health reserves. These are sort of dynamics of costs and benefits that are constantly going on. So in essence, the health insurance structure we have today really has been in place for 20 some years. I mean, it's been in place for 75 years, but the structures are in place for 20 some years. The right to health insurance, outpatient, and hospitalization is written in law, not contracts. The HIP rate what the city pays to all the insurance providers, and then for some insurance plans, employees or retirees pay an additional premium. Employees enrolled in HIP or GHI, which merged together into Emblem in 2006, do not pay premiums, while other plans do. Emblem is still nonprofit, while Blue Cross is a profit-making entity and is a subsidiary of Anthem Health. There are over 400,000 active city employees. There are 250,000 retirees. Those people plus their dependents, approximately 1.25 million people are covered by health insurance by the city of New York. Think about it. That is very big. And all of them continue to receive supplemental benefits through their welfare funds. Now, during Mayor Bloomberg's third term, he had the bright idea that employees are going to start paying co-premiums. The unions all together via the MLC said, no way, we are not doing this. The result was all the union contracts expired. In 2014, when de Blasio was elected, his new labor commissioner proposed an alternative approach to healthcare savings. Rather than co-premiums, he said, Bob Lynn said, if the city can be assured healthcare savings by the unions, that would generate funds to be available to settle contracts. The exact relationship is highly arguable, but we won't go there tonight. But this largely explains why the PSC 2010 to 2017 contract wasn't settled until 2016. So in 2014, and bear with me because I think people want some details here because this is more the coming into the present. 2014 to 18, there was a health savings agreement worth $3.4 billion in savings over 4 years. And going forward, worth a bit over $1 billion. That was largely achieved by HIP agreeing to lower the rate it was asking the city to pay. But there were other things that were done to reduce costs. There was the dependent audit, many of you may remember. There was greater efficiency imposed in a variety of programs. There were co-pays for emergency rooms and urgent care. The agreement also generated, I will say, some additional contribution funds for welfare funds. Remember, drug costs are going up at the same time, so welfare funds needed additional money. So that's kind of the push and pull. Money for the contract, money for welfare funds, give backs on some of the health insurance benefits. Come 2018, Commissioner Lynn decides, oh, that worked once, let's do it again. And so he sought another health savings agreement and approached the UFT, which had a contract to settle. And together they developed a framework for a second health savings agreement, which ran from 2018 to 2021 for a total of over $1 billion in savings, 600 million of which is recurring. Again, savings achieved by reductions in the HIP rate, moving newly hired employees, including at CUNY, into HIP for at least the first year of their employment, more efficiencies in certain programs, incentivizing employees to seek less hospital-based care. I mean, a lot of these things do generate savings. And a series of proposed savings plans where the city could save money that would be discussed by a high-level tripartite committee of union leaders and city representatives with a third party, Marty Scheinman, to serve as a neutral. On that list was Medicare, the proposal for Medicare Advantage. I'm sorry, I'm running a little over, for retirees, which John Hyland is going to discuss next. But I do want to make a point here that the savings from the Medicare Advantage, from moving retirees to Medicare Advantage, is not being accrued to the city budget. That savings is going to the Stabilization Fund. Remember I talked about that having been established in the 80s. That fund is running out of money. GHI rate is well above the HIP rate. It's subsidizing that difference to equalize them. But since 2000, it's also been subsidizing a bunch of other benefits, including welfare fund contributions. Therefore, there is a motivation on the part of the unions to get more money into that fund. To conclude, with 125 million covered lives, the city of New York could exercise enormous leverage in the health insurance market. They have not chosen to exercise that. There are too many entrenched interests in maintaining the status quo, and the entanglements are so complex that undoing them would require an intensive, focused, and collective effort, as well as resources and goodwill. So now I'm going to pass it to John Hyland to talk about the Medicare Advantage plan, which is kind of the cutting edge of what's going on for retirees, but also is important for everyone to understand because these are the kinds of tools that are being sold to municipal governments to save money for active employees as well.
Good evening, friends and colleagues. I'm John Hyland, a retired sociology professor from LaGuardia Community College and a former PSC treasurer. By the end of tonight's session, we want to have started this process of information sharing on retiree health insurance and benefits. And with that, a call to action for the union as a whole to address this issue that has implications for in-service members. So we're talking about something that immediately is affecting the retirees, but has enormous, larger outreach to the whole union. And we want to make this issue a whole union issue. Against the background of Debbie's explanation, more recently, what happened? In July, the Municipal Labor Committee voted to establish a Medicare Advantage Plus plan as an alternative to Medicare, traditional Medicare, and the Emblem Senior Care program that was the supplement to that Medicare program. There was a whole process of negotiation that went on over years in terms of reaching this point. When the retiree chapter became aware that these negotiations had moved to a critical point, we realized we also did not know hardly anything about what the content of it was. So I want to make 3 points in relation to this, the establishment of this new plan. Number 1, the process of negotiation was, from our point of view, seriously flawed, in the sense that retirees and retiree organizations were not part of the process. We were not at the table. We did not know the terms that were being negotiated. And we were in a situation where it began to look like we were going to get a letter someday and saying that your health plan has been changed. We obviously were upset about that, angry about that, and began to resist. We reached out to other retiree organizations, and we began a campaign to question this, basically starting off with a campaign for a moratorium. Stop. Let's get information. Let us know what's going on here. So the first thing is the process itself was a flawed one and left us out of the a deeper sense of participation in it. Secondly, there was a lack of in the plan itself, in the content of the plan itself, there was a lack of accountability and transparency to us. We got a booklet, about a 40-page booklet that laid out what was the content of it. At the same time, we knew that Medicare Advantage plans had a certain history. They had a reputation, and some of that reputation was not good. Some of the aspects of the plans had some enhancements, but there were other aspects of it that were not good. Some of the key issues for the retirees was our access to our preferred doctors. Will we be going to be able to continue to use the doctors who had been treating us, with whom we had built up confidence? And secondly, the whole issue of prior authorization for treatments and procedures. It all involves the basic fact is that this new plan is a private insurance for-profit plan. And so how do you do that? How do you generate a profit while claiming at the same time to provide better services, while at the same time you have higher executive salaries, higher administration costs, marketing, advertising? How could that be? It did not compute for us, and we're still concerned about that. We still have not gotten adequate information about the financial flow and dynamics of that. So the third part of it is, I'm not going to address it. Eileen will go at this. We have to see this as part of a much larger movement within the United States to privatize healthcare, and the serious implications for the whole issue of the public good, the common good. So those 3 things, the process, the content of the plan itself, and its larger implications, are things that we want to continue to educate ourselves about. And in the background is the presence of the fact of a bill for a single-payer universal health care, the New York Health Act. But it's a related issue, but it's not the issue that we're focused on tonight. So I'm going to pass it on now to Eileen. And again, with the reminder, at the end of this meeting, we very much want people to take this seriously as something that's going to touch you and us and our families for generations. And we ask you to sign up with our campaign. So I pass it on now to Eileen Moran.
Hi, everyone. Again, good to see everyone here. And I guess where I want to start is really to locate this, as John says, in terms of the bigger picture, is that what we see happening all the time now is that employers are working harder and harder to make sure that they give their employees less and less. That's why there is so much contingency you know, not only at CUNY, but again, across the board in private and public institutions. It's an attempt to save money. What we know is that the current US system of private medical insurance for healthcare is absolutely unsustainable. It brings us back to where James began. Our vision eventually is a single payer system. And we look to get to that because that really is the best solution for all of us. But in the meantime, as a labor union, we have to be thinking both about our short-term interests and our long-term interests. And what we've seen so far that has already been alluded to, both to the notion that our new hires are confined into like one particular health plan for at least a year, and the kind of savings that are expected to happen by pushing the retirees into Medicare Advantage, just indicates that unless we are much more focused on this issue and how to achieve it and how to achieve our goals, we're going to be stuck with givebacks after givebacks. And that's going to be our challenge as a union. So our challenge in the short term is how do we preserve the benefits that members, both retirees and in-service members, have now? And how do we resist attempts to cut those back, you know, in the short term, as we negotiate contracts, as we are members of the MLC, which is going to be bargaining for our healthcare. But the other thing is, I think at the same time, we have to be thinking about the long term. How are we planning for that single payer vision, which we know is the only sustainable way going forward? It's no accident that both the Clinton administration and the Obama administration pressed hard to try and get health insurance for universal health insurance, or to at least dramatically increase the number of people who had health access to healthcare insurance. And to a degree, obviously Clinton failed entirely, and the Obama ACA was a moderate success in the sense that many more people had access to healthcare. But the Republican resistance meant that as soon as almost that the ink was dry, there was attempts to erode that. And we continue to see those erosions. And that leads us to where we are now, where I think as part of this conversation, we have to consistently be jumping rope and chewing gum. In other words, we have to be working on what we can do locally and in New York State, New York City, and in our contract fights, and hanging on to the members' benefits as they are now, as well as looking for the improvements that will help everyone with a single payer insurance. And with that, I'd like to move on to my colleague, Evie Rich. Thank you.
Evie?
You're muted.
Evie, you're muted.
Hi there. First off, I want to thank my colleagues, all of them, for laying out for you, our audience, the challenge that we all face today and tomorrow. It is important for me to remind you that this is not a retiree issue. It is an issue which faces the in-service people in the PSC, our 300,000 students, and all those people out there in our city who will lose if New York City achieves its goal of transferring the current retirees into a Medicare Advantage program. Our struggle has just begun. And Barbara Caress has made the point, I think effectively, that this is a struggle which has been going on for 60 plus years. This event has done a number of things. First, it has identified the formidable enemies we face. And they are, of course, the insurance companies, the drug companies, and the hospitals, all of which have driven up costs. Those costs have become so great that the city feels that it cannot continue to support retirees and others and our healthcare as it has in the past. Now, none of my colleagues have underscored, as I must, the austerity that underlies these efforts. The city has failed to tax those who have means to provide the resources for quality, affordable, universal health care now and in the future. And John Hyland, my colleague, has pointed out that this is an issue where we have to stand now so that we can guarantee health care, not only for ourselves, but for our children and our children's children. Now, we are lucky because we are educators. We come to this with a special talent. The insurance companies and the other enemy have money, but what we have are numbers and we have talent. We have the ability to fight creatively and imaginatively, to force the city to find new ways to solve this issue. So I challenge you to join us. We in our army of volunteer educators. So first of all, educate ourselves, and then our families, and then our friends, and then the larger union community, and finally, New York City as a whole. What we do today will set the scene for healthcare in this city today and in the future. So I challenge you to join me as we move forward to protect our healthcare, to support the New York Health Act, and to achieve what they say we cannot. However, I've been in this struggle for more than 60 years too. And it's a struggle where we have made significant progress, first in the area of civil rights, okay, then in expanding accommodations for all. And now together, we can do something that has never been done before, that needs to be done, and which will provide quality health care for ourselves and our future generations. Join me and respond to Debbie Bell's questionnaire so that we can tell you what you can do and how you can join us and help us do it. Thank you very much.
Thank you, Evie. We have approximately 15 minutes for questions and comments. If you will please queue up in the chat, and if you will use the reactions link on the bottom, right-hand bottom of your screen to raise your hand, you'll be recognized. So recognizing that there are a lot of us on this Zoom meeting, please try to be brief and Thank you.
Where's the hands?
Are there any hands up?
No, no hands up. Well, we have Robert.
Hi, can you hear me?
Yes.
Yes.
Okay, yeah, I'd like to say that this is not only, stress that this is not only a retiree issue, that those that are still actively employed will be retirees, and they're taking away a benefit that you will hope to have. So please get involved with us. And I want to stress that there are something like 250,000 retirees. If we organize ourselves, we can become an effective political organization. We can be politically active and make a big, I think, impact on the politics of New York City and, in fact, New York State. Thank you.
Thank you, Bob.
Next, we have Nancy Romer.
Nancy?
Yeah, thank you for the presentations. I missed the first few minutes and I apologize for that, but you know, I couldn't agree more with what I've heard. What do we do? You know, what's the strategy to affect this? I understand that the court cases have been successful in pushing out the decision-making date until April, but what's the plan to do something between now and April that can turn the tide? I just haven't seen a clear strategy.
Do any one of the presenters want to respond to Nancy?
I'll respond, Jim. I think that there is a certain inevitability to the Medicare Advantage plan. That said, there will continue to be efforts to hold the city and the alliance, which are the insurance companies running it, accountable for implementing it well, broadly, ensuring that everyone has the access that they currently enjoy, et cetera. The larger question is one of the future, because this is clearly just the beginning of the constraints on access, quality, and cost that we're going to see. The union leadership I'm impressed with the fact that union leaders have, as James indicated, have taken on the question of trying to figure out how do we tackle and how do we push our colleagues in the municipal labor movement to tackle the broader issues of price increases in drugs, in hospitals, and again, hold the city accountable for maintaining and improving benefits. I realize that that's rhetoric, Nancy, but I think that what the officers are trying to do is both educate members. As Bill said, the retirees have gotten, educated by fire on a lot of these issues over the past year, but educate the active members and mobilize around the university and among all the chapters, active members who will work with the Social Safety Net Committee or some other committee to plan things, to mobilize things, and to bring the bodies to bear. As Robert made the point, we have numbers. So that's I think that's the challenge. There are obviously a lot of other things going on, like the New York Health Act, Medicare for All in the Congress, lots of things going on. But a lot of this is education, mobilization, and identifying what's feasible.
Let me just say a note about this. As the famous philosopher and Hall of Fame catcher Yogi Berra once said, it ain't over until it's over. So Nancy, I'm not that optimistic, but we've got a new set of circumstances in front of us. The plan is not going to go into effect until April 1st. A new administration is coming in on January 1st. The PSC has already met with the current controller, and it's going to meet with him again. They're going to meet with the controller-elect probably after January 1st, when Brad Lander is actually controller. Hopefully we can bring some pressure to bear on the Adams administration. But let me also note that the head of Emblem, which is one of the players in this, that's their Medicare Advantage Plus plan. The head of Emblem is on Adams' transition team. But I think that, as Evie and others said, we've got to build up our own forces. And I urge people, I'll put it in the chat again, to respond to our questionnaire and get involved with the Social Safety Net Committee and widen the circle of the conversation that we need to have in terms of implementing our own agency and making things happen. I wish I could be more optimistic than that, but there's still a lot of fight left in us.
Thank you, Bill. There's a question in the chat. What plans are on the way to improve reproductive health benefits and prescription coverage for members?
Get that.
I don't know where we are.
Well, I don't know if there's anybody beyond Debbie who's a presenter who's in a position to respond to that question.
I have one suggestion, Jim. I don't think I think our welfare fund, and Len indicates he might respond, but our welfare fund, particularly on the prescription drug side, I would encourage whoever raised the question to raise some specific issues about problems that he or she is encountering with regard to insurance or prescription drug benefits with Patrick Smith at the Welfare Fund in terms of potential follow-up, because it's, yeah.
Do we have other questions?
No, Jim, can I just jump in and say something? In terms of the question, what is the union's role? First off, I am impressed with the results of the union's efforts to begin with. The Social Safety Net Committee is the committee which went citywide and took to all of the other unions the message of what the city was doing to retirees. The result is that dissident groups within other unions began to speak out. Another result is the formation of this group, which ultimately introduced legislation which provided for the temporary restraining order. Now, some people, very frankly, disparaged our efforts, telling us that we were not going to do anything. We're a little union, 30,000 members, and we stopped a big city government that was taking advantage, as far as I'm concerned, of 260,000 retirees. Now, our next move is primarily to educate our members within the union via the chapters and the delegates. And from there, our union has built coalitions with other unions. I have no doubt that in the long run, we're going to win this fight. And my attitude is, and I see it around me, all of my friends know about this struggle. They are in it. It's unusual in this city to see an older segment of the population stand up to the power structure. And that's what we've done, Nancy, and we're going to continue to do it. And I believe that together with these other groups, the PSC will remain a leader And ultimately, we're going to prevail.
Thank you. Next question is from Len Robert.
Okay, I want to make 2 points. One is that under the advertising slogan of Medicare Advantage, the term Medicare Advantage, which the Congress inflicted on us, what is really happening is a cut in a substantial, basically a 25% cut in the health benefits available to retirees. Every one of us who's a retiree is having our health benefits cut by $2,500 a year. And it's being done because the city decided 4 years ago that it couldn't afford to keep the benefits going the way they are. I challenge that. The city has received billions of dollars from the federal government, and we should be pushing the Adams administration to reverse the position of the de Blasio administration and say it can afford to keep healthcare for its retirees. The other point I want to make is that the reason for this, we talk about the New York Health Act. Let me just say one thing about why we need it, is that the rest of the healthcare system is treated as a market in which every doctor and every hospital sets the rates as high as they can afford, as high as their market will bear. No other country allows that to happen because healthcare is not a market. We can't negotiate. When you're sick, you can't negotiate with your doctors and your hospitals over the prices. We need something like the New York Health Act, or like Medicare, which establishes rates and controls the prices. That's what the broader fight is about. Our local fight is whether our city can afford to provide healthcare for its retirees, and I believe it can.
It's just about 6 o'clock, and so although I think there's not probably, certainly much more to say and certainly much more to do. I want to thank the presenters and James Davis and the union for facilitating this event tonight. And I want to urge you to fill out the questionnaire that you'll be receiving electronically and send it back in. This is an opening salvo in what we hope is going to be a long and very productive struggle to improve our healthcare situation. So everybody, thank you very much, and we'll see you again soon.